I could spend this podcast explaining to you how to interpret your prostate biopsy, but that would mean you have not been paying attention and you got the biopsy that I told you not to get. All right, I get it. Some of you already have had the biopsy and some of you may choose to get one. I support your prerogative, although I have my opinion, and my opinion, well, it's based in a lot of research and experience, but it also has an overlay of philosophy. But it's more important what you derive from it. So what about that biopsy? How do you interpret it? Why do I say you ought not to get one? Well, here are the reasons. First, spread. I know the urologist tells you that the biopsy does not really spread cancer. Logic dictates otherwise. If you stick a needle into cancer and it bleeds, it can spread. If I am taking off a skin cancer, melanoma in particular, and I've done this in my practice, remove melanomas, you have to be very careful to cut the perimeter. You do not want to cut into the melanoma because you can spread it. If I purposefully cut into a melanoma, that's malpractice. Think about removing, say, a breast cancer. The surgeons are very astute in carefully cutting it out, making sure the borders are clean. No surgeon would just recklessly hack into the middle of it. Why then do we suspend our concern when it comes to the prostate biopsy? I maintain it's out of convenience more than reality. Not only do I maintain it, but a study out of Sweden, 2014, they looked at men who had prostate cancer biopsies. Then they took blood out of their arm, peripheral venous blood. And you know what they found? In many cases, they found debris, cellular material from the prostate biopsy in the blood. And in some cases, it occurred 30 minutes afterward. That means it wasn't immediately eliminated. So that's a huge reason to be very contemplative about the biopsy. But wait, how will I know if I have cancer or not? Folks, it's a new era. The biopsies have been around since 1980. We now have an MRI. We can see your gland. We can see the nodules. We have diagnostic testing. PSA is just one of them. There are others. Do they prove you have cancer? No. But then again, does a biopsy prove you have cancer? No. When you get a biopsy, I don't care how precise, how targeted, I don't care how careful, it only samples less than 1% of the total volume of the prostate tissue. So the odds that you'll actually get the material, it's not 100%. You can, remember that game Battleship? You'd have to go blindly try to sink your neighbor's battleship. I don't know, it's kind of a fun game. Maybe not. I guess nowadays, right, if you're listening to this, you probably remember it. Kids nowadays all like video games. Anyhow, back to the biopsy. They are sticking needles into the prostate gland. Prostate cancer is not organizing itself into a neat little nodule. It is speckled and disseminated at its origin. So the idea of targeting it, they may say, well, we can target it with an MRI-guided biopsy. Maybe so. But the Gleason score, this is what we're talking about now, and Dr. Donald Gleason arrived at his interpretive judgment, subjective judgment about what these cells look like. It's back in the 1970s. And, I suppose he did us a service. He did his best. He's a pathologist, right? He wanted to categorize those cells. What do they look like? And he did do that. But over the years, the categories have shifted a bit. And the way they're reported is different in America, say, versus in Europe. Imagine they're looking at 20 different biopsy specimens. Well, how do you report that? The most aggressive looking one, the most pathologic looking one, or the average amount? In the US, they go for typically the most pathologic looking one, versus in Europe where they tend to aggregate them. But does this all really matter? Does it make a difference? And it may not. So now we can get to a reasonable degree of certainty. That's what we're after, folks. If you want guarantees, ain't going to happen in medicine, and it will not happen regarding your prostate health. You must live with uncertainty, just a matter of what type. But I want reassurance. I want a biopsy. Okay, so they do the biopsy. Suppose it comes back and shows no cancer. I already told you they've only sampled maybe 1% of the material. Is there really no cancer there, or did they just miss it? You don't know. Uncertainty will persist. And furthermore, what happens next? I had a biopsy done in June. How about a year from now? Should I get another one? See the dilemma that you're painted into? And suppose it does show cancer. Does that make a difference regarding your decision about treatment? I mean, I suppose it might. I suppose psychologically, right? If you have biopsy-proven cancer in your prostate gland, you might opt for surgery. Take it out. It's comforting. Psychologically, it seems to make sense. It just doesn't seem to make a big difference regarding your survival. This is a real dilemma. I mean, intuitively, if you cut a cancer out, you shouldn't then die from it. That's the objective. That's the gold standard. Cut it out, I don't die from it. The PIVOT trial, published in the New England Journal of Medicine, looked at men who had the prostate gland removed versus those who did not. And they followed them for 20 years. And they found no significant difference in death from prostate cancer in either group. I know that's disturbing, that men who left the gland in place had statistically the same risk of dying from prostate cancer as men who had it removed. That's not what you bargained for, is it? You take the gland out, you do not expect the cancer to then take your life. I wouldn't mind so much the aggressiveness of treatment if it weren't for the devastating consequence. Leaking urine, sexual dysfunction. It is heartbreaking. We need to push forward. We need better techniques of intervening. How do you manage the uncertainty? Doing nothing is uncomfortable. But does it matter? Suppose you do a biopsy, and by the way, in the PIVOT study, they did categorize the disease based upon the magnitude of pathology, that is, the Gleason score. So let me talk about that for those of you that have had a biopsy or are curious thinking about it. The Gleason score is a numeric categorization about how funny the cells look. If they look not bad, they are given a score of 6. Now, the score goes up to 10, but it really starts at 6. So if you get a Gleason score of 6, it doesn't imply that you're past the halfway mark. In fact, a Gleason score of 6 has the same risk of dying from prostate cancer as somebody who was never diagnosed with it. So it's been argued that there should be another label applied to a Gleason score of 6, not cancer, but something else. I maintain that consideration should be applied to prostate cancer in general. Atypical dormant cells is a nomenclature that I advocate for. These are cells that are in the gland and aren't going to do much. They just stay there. But how do you know the Gleason score 6, 7, 8, 9, 10? It is true that the higher the Gleason score, the worse the prognosis. You're more likely to die from prostate cancer with a Gleason score of 8 or 9 versus 6. That's true. What is not true is that you can use that score to make definitive judgments about your best path of treatment. Because in the trials, it doesn't appear to have a huge difference regarding the outcome. It is understandable that if you had a high Gleason score, you might be inclined to want to do something more aggressive, and I can't blame you if you did. It does appeal to logic. After all, nobody wants to die. But worse than dying is suffering withering consequence, losing your manhood, and then dying. So the Gleason score, it's the way it's reported. Sometimes they'll call it a more aggressive cancer. Suppose you get a Gleason score of 8 or 9. Well, number one, you did the biopsy. I told you not to do that, but that's okay. It's okay. It's your prerogative. So a Gleason score of 8 or 9, they'll call that aggressive. How can you tell? It is a statistical reality that if you have 1 point on a curve, you can make no judgment about what comes next until you get another point, right? You got to see progression. Aggression is not defined by the stagnant nature of any entity, but rather what it does over time. A tank can be considered aggressive, but if it's in park and it's sitting there, not much. It's when it's moving. So let's translate that into the prostate. One of the reasons that I like non-biopsy assessments because you can sequentially monitor them without causing harm, without risking disseminating cancer. So you can do a prostate MRI. Let's follow the breadcrumbs. PSA is elevated and staggering in interval. You do it 3 months later and it's starting to creep up. The next step, in my view, should be an MRI of the prostate. And the MRI of the prostate, if your PSA is above 5, let's say if it's above 10, you may find some nodules in there. That does not mean you go biopsy them. It just means you have nodules in your prostate. But are they cancer or not? You don't know. There are features that can help guide that thought, and you can make a reasonable judgment about what's there. Then you can do things to make your body more resilient against cancer. Now, we've talked about some of those things, and we'll continue to do that, but they're not surgery. They're not radiation. We're not talking chemotherapy. We're talking stuff you can live with. Then you can repeat the study 3 months later. If you have the MRI is gauged on what's called a PI-RADS, 0 to 5, you go from a 3 to a 4 or a 5, that's evidence of progression. That means whatever it is you're doing at the time, it's not quite enough. Maybe you got to do a little bit more. So interpreting the biopsy implies you did the biopsy. Interpreting the biopsy implies that it has tangible merit, concrete evidence of a path forward. It does not. It's not to say that the treatment approaches are irrational. It's just to say they're unproven. Do not let any surgeon tell you they're going to cure your cancer with surgery. They can't do that. They shouldn't say that. The research does not support that. They should be saying, we're going to attempt to prevent cancer progression. We hope that this is a curative procedure, but for the rest of your life, we'll have no way to know. The literature and clinical experience is replete with men who had the prostate removed only to have the cancer come back. So uncertainty will be with you forever. My goal for you is to have vitality always. Death comes, but it ought not to be preceded by a withering phase of life. Vertical life, we call it vertical living, right? Stay vital, and then boom, a quick death at the end. Hopefully at an advanced age, hopefully not from prostate cancer, but no matter the path you pick, you don't get the guarantee. And the biopsy does not help with the outcome decision making. It's difficult. The reason I don't like biopsies, dissemination, lack of correlation to help guide definitive treatment options, and the need to do them again to see what goes on. I hear a lot of histories of men who suffered from the biopsy itself, lingering pain, sexual dysfunction from the biopsy, and it can happen. If you're inclined to get the biopsy, be advised that the Gleason score will come to you, but the Gleason score is just the pathologist's best guess. You could look at 2 different pathologists, and they can come up with 2 different Gleason scores of the same biopsy. So perhaps that's a tip I can give you. Have that biopsy specimen interpreted by an independent pathologist. Would they agree that the Gleason score is the same? But does it even matter? It comes down to, how do you want to manage your prostate? What are you willing to risk? And what are you hoping to gain? I maintain that if you can take a deep breath, that's the biggest advice. Go slowly. You have time. No matter the status of your prostate or the cancer, there's never a rush. So do not jump at the first recommendation of treatment. Give yourself reflection, even if it's only a few weeks. And then decide how you want to live your life. Would you accept a compromise in your vitality through the surgery of removing the gland or through the radiation? Would you accept that? Would that be a fair trade in your mind? Very individual. It's a very individual decision. A lot of it has to do with what you value. For some men, the notion of leaking urine or losing erectile and sexual function is not a big inhibitor. I respect that. It's your life. It's your prerogative. That's how you're going to roll. but the biopsy itself, the Gleason score, how to interpret it. Perhaps this has helped a little bit, that it is, I like it, that old cliche, when you can't measure what's important, you give importance to what you can measure. We like numbers, we like scores, we like protocols. Prostate cancer treatment based on a Gleason score has been an empirically derived treatment pathway without proven benefit and outcomes. Not to say it's wrong, it's just not as concrete as we wish it were. So with that mire of uncertainty, we move forward, men. Not a guarantee. Here's what I hope for you. Here's what I hope for me. I want to die with prostate cancer cells in my gland because it means I lived long enough to get them. Because if you live long enough, it is almost inevitable that there'll be cancer cells within the gland and that they will, in all likelihood, stay there. This could be considered a normal progression. These atypical dormant cells can be considered normal for an aging Homo sapien male, and as such, should we be intervening aggressively? Food for thought. You know how I feel. Keep your prostate, keep your manhood, don't let them irradiate you, accept the journey forward, accept the uncertainty. The thing you can be certain of is treatment will cause harm. That's about the only guarantee when it comes to conventional pathways. What you can be certain of is no matter whether you follow my recommendations or surgical irradiation, the outcome will remain uncertain. But we can always move forward. That is, you can go from a non-surgical, non-radiation pathway toward that if you choose to. But when the prostate's taken out, you can't put it back. Same thing with radiation. You can't put that toothpaste back in the tube. So folks, the biopsy should be predicated based upon what would you do with that result. Don't do the biopsy before you contemplate how you want to manage your prostate health. If it shows cancer, what would you then likely do? If it doesn't show cancer, you're still in a conundrum. The reason they did the biopsy is because they thought you had cancer. It comes back negative, may not be convincing enough to make them not want to do another one in the future. Conversely, if you have a MRI that shows a PI-RADS of 5, very likely to be cancer, and you have nodules in the prostate, worse yet, suppose there's evidence of dissemination, do you even need a biopsy when all the arrows are pointing toward certainty of diagnosis? So I maintain my position. A biopsy is not terribly helpful, not always necessary, that we now have a non-invasive means of assessing between the prostate MRI and, if needed, a prostate-specific membrane antigen PET scan. These are non-surgical pathways that surgeons are not likely to embrace anytime real soon. It's incumbent upon you to do your own homework and direct your care, even if that direction is not aligned with what's given, the advice that's given to you. All right, team. Well, that's all I got for today. Thanks for spending time with me, and continue your reflections. Remember, you have time. Consider multiple sources, but don't go it alone. Don't go down the rabbit hole of internet-based arbitrary treatments. You need to have a partner. You need to have your family doc. You need to have somebody who can look at the whole picture. And yeah, oftentimes you need a urologist, maybe even an oncologist, part of the team. All right, gang, until next time, look forward to the conversation.